Very good evening to one and all of you, dear friends who are watching this webinar. And it is special thanks to Dr. Namrata Sharma for involving us in this initiative of hers along with J&J. And thanks to J&J for including us in the scheme of events. And this session is about Learn from the Masters. And we have very able surgeons here from the Eye Foundation group of hospitals based at Coimbatore, who are going to take you through different case scenarios with different lenses. So we look forward to good discussion and make it a very fruitful 1.5 hours for all of you. So without wasting time, we'll start off on and of course, most importantly, a very warm welcome, Dr. Namrata Sharma, whom we all know is one dynamic chairperson scientific committee of the All India Ophthalmic Society, who has set no boundaries as to how the scientific content of AIOS is to expand. So that is how the growth is just like exponential, and it's phenomenal. And thank you, Namrata, for keeping us all learning every minute of your tenure. And a very warm welcome to you, Dr. Ramurthy. We all know he's the chairman of the Eye Foundation group of hospitals and is also a past president of AIOS. And I'm sure between the two of them and with me this meeting will be answering many of the questions which may be lingering in your minds. We shall go on with our first speaker, Dr. Tamanarsi, who's a senior consultant cataract services as the Eye Foundation group of hospital, and is also our very versatile surgical trainer and a great teacher for our fellows and postgraduate, so DNB students. And let's hear what she has to tell us. On to you, Dr. Tamal. Can you unmute yourself?
Ma'am, I'm unmuted.
Yes, we can hear you. You can show your video.
Can you share the screen?
Yes, ma'am.
No,
Good evening, one and all. Today I'll be presenting my surgical video on phaco with implantation of a refractive EDOF and toric IOL.
Can we just mute everybody else? Yeah. Yes, Tamarasi, continue, please.
Yes, ma'am. My patient is a 56 years old gentleman who had defective vision in the right eye for 3 months duration. The vision in the right eye was 660, improving to 612, and the patient had a nuclear sclerosis grade 2 cataract. The fundus and the OCT macula were normal. And this is the biometric printout from IOL Master 700, no financial interest. And this is a printout which shows the quality metrics and which, as a surgeon, we should know whether the quality of the measurement is good or not. We know that the axial length measurement is almost accurate in all the available optical biometers. And the IOL Master printout also gives the fixation check where we have the OCT macula scan. And we can see the foveal pit. It tells that the fixation check is good and the axial length measurement is accurate. And the most significant error happens in the keratometry measurement. And the most common source of error is the ocular surface disease, for which we can look into the reflection of these LED mires. If these are crisp, it tells that the ocular surface is good. And also we have this topographic map, which shows a regular astigmatism with no islands of flattening or steepening, again ensures that the readings are accurate. Another pointer is the standard deviation value, which should be less than 0.3 diopters. Once we know that the quality is good, then we go to the measurements per se. The axial length is 23.93. The patient had a shallow AC of 2.43 with a corresponding increase in lens thickness. The patient had a total keratometry of TK value of 0.84, and using the Barrett TK toric formula, the spherical power suggested was 23, with a cylinder at the IOL plane at 1 diopter, 1, and the implantation axis is 175. And to the left, what we have is the J&J toric calculator. Once we enter the patient details, eye, and the spherical IOL power and the axial length, the reading which we have to enter is the surgically induced astigmatism, which is a centroid value of 0.1 diopters. Since it's right eye, I place my incision at 180 degrees, so it is 0.1 at 180 degrees. And we have the option of choosing the posterior corneal astigmatism as yes. It has a nomogram which takes into account of the posterior corneal astigmatism and gives the toric IOL power to be implanted. If you're going to keep it as yes, always make sure that you enter the standard K value, which is here is 40.28 flat and 41.06. The toric IOL power recommended and the access is similar to that suggested by Barrett toric TK formula with a residual cylinder of about 0.15 diopters. So now we have a moderately dilating pupil NS2 cataract in a 54-year-old gentleman who is also on alpha blockers. So I can anticipate IFS in this case. The IOL, he wanted a spectacle independence without compromising the quality of the vision. And he was counseled for this refractive EDOF. And he was also apprised the need of use of readers when he's going to read small prints. So we went ahead and implanted refractive toric. The implantation axis planned for is 174 degrees. Coming to the surgical video, I'm using a Varion image guided system. And once the registration is done, we have the digital overlay, which shows the pre-planned side port incision and the main incision. The first precaution what I'm taking in this case is to make a narrow side port incision than usual. Both the side ports are narrow. This prevents the fluid efflux. Once the fluid efflux is reduced when using the chopper or dialer in the second instrument, the stability of the anterior chamber is maintained and hence decrease the risk of iris prolapse. The second, what I'm doing is injecting a phenocaine, which is a combination of lidocaine, phenylephrine, and chlorphenamide. Though the pupil did not dilate, the phenylephrine increases the tone of the dilator muscle. I also noted no billowing of the iris. This tells that the tone of the iris is not too flaccid or floppy. Again, now I'm injecting visco, which is HPMC. The pupil didn't dilate well, but I'm not over-injecting the viscoelastic. Now a 2.4 millimeter temporal clear corneal incision is being made. The care what I'm following here is not to err on a shorter tunnel. Slightly longer anterior tunnel would decrease the predisposition to iris prolapse. I enlarge the inner lip to a little bit so that the incision is slightly trapezoid. Viscoelastic is again injected to remove the air bubble. Now I have a pupil size of around 4.5 to 5 mm, NS2 cataract. The tone of the iris muscle is not too flaccid. Just the comorbidity is that there is a shallow AC. So I decided to go ahead with phaco without using a pupil expansion device. And I would use it if the iris prolapses or there is a progressive meiosis. The first and foremost care is aiming at a rhexis of around 4.5 to 5 millimeter. The patient was a little apprehensive when he was moving, and I reassured him verbally just to look into the coaxial light reflex. I'm just aiming a rhexis of around 4.5 to 5 millimeter. Care should be taken not to make an undersized rhexis because it is going to add to the complexity of the procedure where I can have a capsular blow-off, nucleus drop, or just a posterior capsule rupture. Dealing with a small pupil phaco is little easy than a small rhexis phaco. And while propagating the rhexis, make sure that the anterior chamber is not shallowing because when the AC shallows, the pupil size comes down. I'm just aiming the rhexis to be at the pupillary margin or slightly outside of it by constantly positioning the flap flat and repeatedly redirecting it. So that this ensures that an adequate sized rhexis is got or my rhexis is also not extending. I could have used tryphan blue for this procedure, but since I got a good red blue, I opted not to use a tryphan blue in this case. So after completing the capsular rhexis, the next step is the hydrodissection, which has the highest chance of increasing the risk of iris prolapse. So I burp out the viscoelastic a little bit, slightly keeping the anterior chamber a little softer, and just went behind the rhexis, slightly tented it up, and injected small jets of fluid in multiple quadrants, what we call as a multi-quadrant hydrodissection. Either injecting forcefully or injecting too much of a fluid can cause increase in the pressure gradient behind the iris, which could again increase the risk of iris prolapse. I thought that I could see a good fluid wave and I went ahead and rotating the lens. Though I could rotate the lens a little bit, but it was not rotating freely as I would like to. This could be because the fluid which has gone inside has not created enough hydraulic pressure to separate the capsule from the cortex. So in such cases, never attempt a forceful nuclear rotation, which could cause a zonular dehiscence. So never hesitate to go back and repeat your hydrodissection. Here, when I'm injecting, I could see that the lens moving a little bit forward. So I stop injecting, let the fluid out by burping the lens, tapping on the lens, and I repeat the hydrodissection. If at all iris prolapses at this stage, we should not push back the iris or inject too much of a viscoelastic. We should decompress the lens, let the fluid out, or else decompress the anterior chamber, let the viscoelastic out, and sweep the iris through the opposite paracentesis. Now the nucleus is rotating freely as I'd like, and I'm proceeding with the phacoemulsification technique. The phaco machine, what I'm using is Veritas phaco system. And here we have the advanced ellipse effects technology, which is a blend of a longitudinal and transversal phaco, which gives better energy efficiency. And this longitudinal phaco gives the advantage of not clogging the phaco tip in case we are dealing with a hard cataract. The technique what I'm using is just a stop and shot technique. I'm just restricting the length of the tunnel just short of the iris. Since iris is near the high fluidic current, there is a chance that the iris can get caught in the phaco tip. So always ensure that the phaco tip is in the center of the pupil. The length of the trench is extended on the other side. And in the biometric printout, we know that the lens thickness was slightly 4.89. So I deepen my trench. And now I have 2 heminucleus. Now it is time for chopping the heminucleus into quadrants. There is a space created by the trench, which gives me space so that once chopped, I can emulsify the quadrants within the back, not lifting up in the iris plane or coming back to the anterior chamber. If I'm going to lift to the iris plane, the fluidic currents can go posterior to the iris and again can irritate the iris. If I'm bringing it anteriorly, then I could compromise the endothelium. I just wanted to rotate the nucleus and complete the phaco in one go, but the patient again started moving. So I have to come back, repeat, inject viscoelastic. In cases where there is a high chance of iris prolapse, whenever we are coming out and going in the anterior chamber, it is better to go in foot pedal position 0 with irrigation off and then switch on to foot pedal position 1. We know that the iris goes wherever the fluid flows. So this prevents the iris prolapse. So far, the pupil is holding on well to the same size. Now I'm chopping the other heminucleus into quadrants. If at all we accidentally engage the ultrasound power to the iris tissue becomes shaft and we get this fibrils of iris. Once the fibrils are there, it comes repeatedly onto the phaco probe and this becomes a vicious cycle and it's going to aggravate the condition. So always stay in the central safe zone. The epinucleus is there. I'm just trying to remove the epinucleus. Usually in a dilated pupil, I would get it in toto and carousel it into the anterior chamber. But now I could remove the epinucleus all places except this subincisional area. So I thought I would remove it along with irrigation and aspiration. Since I made my side ports narrow and now I'm enlarging into the desired extent so that I'm going to use the bimanual irrigation aspiration. I'm comfortable and using the bimanual irrigation aspiration because it maintains the chamber stability and gives 360-degree access for cortex aspiration. The Veritas, it has a dual pump technology. So now I've switched to the Venturi mode. Now the air bubble is being not aspirated because of the clogged aspiration probe. So I have to change in between. So once the probe is changed, you could see that we can aspirate with ease. And there was a small epinucleus sheet, you can see that which is getting aspirated. And eyes with small pupil and dense arcus, we can get the small epinucleus pieces, which can get hidden in the limbus or under the iris. So whenever we see the small epinucleus sheet, it is better to remove then and there. Now the cortex is being aspirated all quadrants. Surgeons who are used to using coaxial irrigation aspiration, when they are using it, it is better to retract the irrigation sleeve little up so that the aspiration and irrigation happens at different plane. If they're not retracting, the irrigation will be at the level of the iris and this could again predispose to iris prolapse. So once the opposite quadrant is done, now exchanging the irrigation and aspiration and doing the subincisional part. Here I'm expecting the epinucleus is also. So when we have the epinucleus, when we're going to aspirate the cortex at that quadrant, the epinucleus automatically loosens up. So I'm now aspirating the cortex. This epinucleus is already loosened up. So again, now this cortex is aspirated. The epinucleus is totally loosened for aspiration. Sorry. So once the cortex is aspirated, hydropolishing is done. There are few fibrils of cortical fibers attached to the posterior capsule. So usually a hydropolishing is effective in removing these small posterior capsular fibrils, which is there sticking onto the capsule. I usually implant the lens in using visco. So I'm using a HPMC to slightly inflate the bag. And the IOL, what I'm implanting is a refractive EDOF IOL, which is a pure C. And the delivery system, what is using is a preloaded simplicity delivery system, which is very easy to use. You have to just hydrate the lens, advance, and implant the lens in the bag. This refractive EDOF is based on the tried and tested platform of Technis, which corrects the spherical aberration and chromatic aberration. And the posterior surface is changed for giving the extended depth of focus, which is there is a continuous power change in the posterior surface, which they call it as a continuous power technology. And we can see that there is no discretions or elevation in the optic. The optic looks very similar to that of a normal monofocal lens. And usually the depth of focus and the quality of vision are inversely proportional. But here, giving the extended depth of focus from distance to intermediate of 50 centimeter, and in a good number of patients, they can read even functional near. The quality of vision, when you compare it, is similar to that of a monofocal IOL. So I just place the lens 3-degree off axis of the intended axis of implantation, and I start to remove the viscoelastic. Again, I'm using a Venturi mode. First, the viscoelastic is removed in the anterior chamber, and then at the level of the iris. And since the pupil is small, I was a little hesitant to go under the iris. Initially, I tried the rock and roll technique of just tapping and moving the lens. And later, I just took the irrigation alone behind the IOL just to remove the viscoelastic behind the IOL, because that retained viscoelastic behind the IOL is the most common cause for IOL rotation in the postoperative period. While aligning the IOL, make sure what you see here is a hyperbola, and there is a small ball which is moving within that. So this ball should be within this hyperbola, and the tracking has to be okay. If this tracking is okay, it tells that the eye is aligned, and we are going to align the lens. So I'm just using the dialer to retract the iris and check on the alignment marks. So you can see the alignment marks, 3 dots here. And also the Purkinje image is just in the crosshairs where these marks meet. So with the irrigation on, hydrate, give intracameral moxifloxacin, and do not overhydrate the wound, which could again cause the IOL to rotate, and give a posteriorly, just when aligning the lens, just nudge it posteriorly so it sits on the posterior capsule. And also check the IOL position after removing the speculum also. So this is the post-op result where the patient had a good distant vision of 6.6 and N6 also. Thank you.
So thank you, Dr. Tamalarasi. I think that was a perfect demonstration and narration. I think I must congratulate you on your narration, especially because it was so clear of a case with small pupil phaco with possibility of IFIS. I think you really managed very well and very nicely differentiated between small pupil phaco and small rexus phaco. I think that was also something which was highlighted, and all of us would be tempted to put at least some pupil expansion device here, but you still carried on, and because when you have small pupil, then people tend to demonstrate that. But I think this is another way of doing it, that you don't use any expansion device, and yet because of the elegance of the way you did the case, you still were able to complete it really very well. So if there are any questions, Dr. Ramamurthy, would you want to comment on it? I think excellent job done.
As you mentioned, it was an excellent demonstration, and I think the fact that she took a couple of minutes to explain the need for a toric in the sense that, that was a Barrett toric calculator that she used, and even for a 0.7 diopter cylinder, especially when you use these premium lenses, correcting the cylinder is a good idea, and that's the reason it was a toric POC. And apart from the features of the POC that we'll discuss further also, one of the other factors when we use this lens is that it's based on the Technis 2 platform, where the haptics are roughened so that, post-operatively the propensity for these lenses to rotate is also much less, which adds to the stability of these lenses. One question to you, Tamil. I mean, you obviously this was a small pupil, and as Dr. Amrita said, you managed without any expansion devices. Did you alter your phaco parameters, and was there an advantage of using a system like Veritas over the earlier Signature Pro, which we are all used to?
Yes, sir. Actually, I didn't mention about the phaco parameters because I didn't change it. Initially, when I started injecting phenocane, and later on also the iris tone was not too floppy or flaccid. So I thought that reducing the parameters is not needed in this case. But if at all the iris has a tendency to prolapse, I would have a little bit reduced my parameters. But Veritas also provides a good chamber stability because of the advanced tubings and the fluidics it has. But in this case, I did not change it, sir. I did not reduce my parameters.
To get a nice Rexis, would you have some special tip for the staining technique which you would adopt in these cases? And the second question is, when would you take a call that you're going to use a pupil stretching, the expanding device?
Yes, ma'am. First, to answer your first question, like in a dilated pupil, staining would be really easy. But in case where your pupil is mid-dilated, sometimes only the dilated part will get stained. And when we use the pupil expansion device, the ALC, which was under the iris, would not have stain. So it's better to inject few drops of Trypan blue under the air bubble just to go under the iris tissue and place it and leave it for like around 25 to 30 minutes. So that gives a better staining of even the iris under the
seconds.
ALC under the iris, ma'am. And the second question, ma'am.
No, when at this point the surgery went on elegantly, when would you use the expansion device? When would be the turning point?
If this patient would have had any hard cataract or PX of any other ocular comorbidities, I would not hesitate to use hooks from the beginning, ma'am. Or in between, as I said, if the iris has started prolapsing or if there is a progressive meiosis, I would not hesitate to use even iris hooks in the middle of the surgery.
One thing I would have done a little differently is that I would have stained this capsule also. As you said, you very elegantly ran it along just beyond the margin of the pupil. But I also want to see the rexis and the leading edge very clearly. And when you stain it whenever I have a mid-sized pupil and I'm not using a pupil expansion device, I tend to stain it, and I think that helps me to gain a little more control over the rexis.
Yeah, that's what she said. And the other thing which I asked, you say that you use your Venturi of Veritas for the IA and removal of visco, right?
Yes.
Yeah, and the other thing is, the last question which I would want to ask is, how do you think Veritas machine actually helps in surge management to a small extent?
As I said, that it has advanced tubings which helps to prevent surge, and also the automatic occlusion sensing is also there, and we can just use a differential aspiration flow rate and vacuum pre and post occlusion. So we can operate with a higher flow rate and vacuum before occlusion, and once the occlusion happens, we can even customize what is the vacuum and the flow rate what we want, so that there is no sudden drop in anterior chamber pressure, and it helps to prevent surge.
Yeah, Dr. Namrata,
I think we should move on. Yeah.
I think let's move to the second case, and Chitra, will you introduce the next set?
We look forward to hearing from our Soundarya Balaji, who's the consultant cataract and refractive services, cornea refractive services from the Eye Foundation group of hospitals based at Chennai. And she has been with us earlier in our Coimbatore branch. So and we know that she's quite a versatile surgeon. And she's going to be presenting a case of a Relax Smile on the Silk platform. So on to you, Soundarya.
Thank you, ma'am. First of all, I would like to thank Dr. Ramurthy sir, Chitra ma'am, Namrata ma'am, and AIOS and J&J for giving me this opportunity. Can we have the video, please? So I'm going to be shifting a little away from the IOL topics and talking about the Elita Silk platform, that is a smooth incision lenticular extraction. Share the video, please.
Yes, ma'am. Just a minute.
Yeah. So before going into the surgical video, I just wanted to highlight a few preoperative things that we usually do. One is, as with any refractive surgery patient, we do all the extensive workup, the subjective refraction, dilated fundus examination, the dry eye workup, and most importantly, the topographic screening. And once these processes are done, sorry, I'm not able to play the video.
So, no, I think you need to just play. Yeah, now we can.
Yeah. Can we pause the video, please? Okay, yes. So two other preoperative precautions that we usually do in the case of silk are, one is the astigmatism or the axis marking, which in any case with an astigmatism of more than 0.75 diopters, we prefer to mark the 0-180 axis with the patient sitting on the slit lamp. And the other thing is the centration marking. So this, we take the patient inside the OT, we make them lie down supine, and under the microscope, we do the centration marking, which can either be centered on the pupil or on the visual axis based on what the surgeon prefers. And once we go ahead with the procedure, yeah. Sorry, I'm not able to control the video. Can we pause it? So here, this is a patient with a low myopia of 1.75 and -2, and the astigmatism was quite negligible, so we did not do the axis marking. And the other thing we can notice here is something called the sphere adjustment and the cylinder adjustment, which is basically based on the normogram given by the Elita machine, which usually compensates for the undercorrection. And as we can see here, we also enter the K1 and K2 values from the topography. The optic zone is usually kept at around 6 mm, and the total treatment zone is around 8 mm. And we can also change the incision arc length, which can be varied between 2.5 to 3.5 mm. So here we have kept a 3.5 mm. And the cap thickness is usually kept at 110 microns. So there is another thing called the flat add, which is basically the equivalent of the minimal lenticule thickness that we do in SMILE. So this is a non-refractive add that is basically added in between the anterior and the posterior refractive surfaces. So this can be varied between 15 microns and 30 microns, and this makes it easier for the lenticule extraction. So here, in cases like this with a lower myopia, we usually go ahead with a 30 micron add. So, yeah, so the first step, basically the patient interface consists of two parts. One is the cone, as we can see here, and the other is the suction ring. So the cone, usually we have to make sure, fit it in the machine and make sure that you hear the click sound. And here I'm just going ahead and wetting the corneal surface and drying the conjunctival surface, which is very important because we don't want excess fluid, which can lead to a false meniscus during the applanation. And also, if there are dry spots or debris, it can lead to dark spots. So here I'm using the joystick to move down the cone.
Okay.
And so this is the second part of the patient interface, which is the suction ring. And as you can see where my fingers are holding, that is where I'm going to be pinching to cause the applanation. And we need to make sure that we have a uniform 360-degree scleral rim that we see and make sure that it is well centered. This is the most important step. Once this is centered, our docking becomes much easier. And then we again move down the cone to achieve a 50. And here I'm pinching, and we have to make sure that the meniscus surrounds the treatment zone all around and in 360 degrees. So sometimes we may not achieve the 360-degree overlap. We may have to tilt the suction ring a bit. And by doing this, we can finally go ahead and center it. There is also a continuous surface scanning that happens. Can we pause the video, please? There's a continuous surface scanning that happens, which compensates for any tilt in the applanation surface. So we don't have to worry about that. And as we can see here, the laser takes just about 17 seconds for the entire process to happen. And also, since it is the scleral suction that is happening, the chances of a suction loss are very less. And the IOP rise is about 18 millimeters of mercury. Can we play the video, please? So here first we have and we also again, we center it according to our pupil centration. So the laser starts firing the posterior surface, the side cut, the anterior surface, and the incision cut. Once this is done, we undock. And after this, the lenticular extraction is pretty much similar to any of our lenticule procedures. We find the different planes and then we go ahead and dissect the anterior plane first. So here, these are ultra short pulses and they're extremely small spot size. It's just 1 micron. And the spot spacing is also very negligible with just 1 micron differences. So the tissue bridges are quite easy to separate. And one major standout point in the silk machine is the biconvex shape of the lenticule. One advantage is that it equally distributes the refractive correction in both the anterior and the posterior surface. And also it is said to have lesser corneal damage, thus resulting in faster healing. And also the post-operative corneal microfolds that happen post-lenticular removal are also said to be lesser. So here I'm going ahead and dissecting the posterior surface, and I also usually like to fold the lenticule over itself so that it's a little easier to grasp. And the energy that we use, usually here what we've used is for the anterior surface 38 nanojoules, and for the posterior surface it is about 40 nanojoules. And we can customize it and change the energy according to our post-op results. So we are going ahead and removing the lenticule, and I usually like to examine the lenticule whether we've removed it in toto once we've removed it. So another advantage actually with this is the easy identification of the anterior plane. But interestingly, in this patient, in the other eye, I did have an anteriorly stuck lenticule. I just wanted to show the highlights. So here I've gone posteriorly. And I'm making sure whether indeed I've gone posteriorly or not. And then I just wanted to show the technique that I used to find the anterior plane. So this is one thing we can do. We can go towards one of the sides and tent up the instrument and give 3 or 4 scraping movements and then find the anterior plane. So once we find this plane, the dissection becomes easier. Especially in these kind of low myopes, it can be a little challenging because the lenticule by itself is a little thinner. The other approach can be done through the incision itself. At the incision site, we can just go tent up the instrument and identify the anterior plane. This is extremely rare, and this is the first time I've had this. And especially with the biconvex lens, it's pretty much easy to find the anterior plane in the first go. About the surgical part, and post-operatively, this patient had a 6/6 and 6/6 part vision on day 1. And currently, silk can be used to correct up to -12 diopters of sphere and -6 diopters of astigmatism, with a total spherical equivalent of -12 diopters. And if I'm not wrong, I think even for pure cylinders, it can be used. But we haven't tried that yet. Thank you.
So thank you, Soundarya. I think, again, that was an excellent surgery. And what I liked was that you showed a case where, people might get stuck and not know what to do, but so effortlessly and easily you did it. So Dr. Ramamurthy, I just wanted to understand from you, you've done pure cylinders on this machine. And what is the highest that you've done on this machine?
Actually, we have done about up to -7 diopters. Because usually up to about -7 diopters, and equivalent power of sphere and cylinder put together up to about 8. It's just that the machine is capable up to 12 diopters, but then as a rule, we do not, whenever it's beyond 8 diopters, we shift to more towards phakic intraocular lenses. Otherwise, we have found the results to be quite gratifying. The good part is that a significant amount of cylinders, even up to 3 diopters of cylinders, it gives a fairly good results.
And you have both the lenticular platforms, I believe, the Silk and the Smile. How do you think, I wouldn't say who outscores which one, but how do you think this is technically different from, I mean, if suppose somebody is doing Smile and shifts to Silk, how do you think technically it is different from the way you do Smile? Or is it just the same?
Well, I mean, as far as the lenticule removal is concerned, it's exactly the same. There is not much of a difference, but it is a docking procedure that's a little different. And then there's a scleral suction in this compared to a corneal suction there. So especially with the Visumax 500, when we had, one of the issues that we faced quite often was loss of section, and there was a set procedure to how to go about once you lose section as to remove the lenticule. Even though now it's less of an issue with the Visumax 800, where the amount of time when the suction is on is very less. But in this platform, one thing is the duration of is only about 17 seconds of laser firing. And second thing is it's a much stronger scleral section, because of which, even though we must have done about 500 odd eyes, we have not lost section with about half a dozen surgeons doing. There's not even a single case where we have lost section. I think it's a combination of both these factors. Initially, we were concerned a little bit about the occasional subconjunctival hemorrhages that we saw, but once we started putting a drop of phenylephrine preoperatively, that also seems to be less of a concern in most cases. And otherwise, I think the biconvex lenticule seems to be an advantage because none of the other platforms have it. We have a Zima machine also with us. Would you like to initiate, Saundarya, as to what do you feel are the advantage of this biconvex shape of the lenticule?
Yes, sir. That's what the one thing that usually they say is the equal distribution between the two surfaces. And the other thing is, I feel, I mean, that's what, apart from this case, I found it very easy to find the anterior plane, much easier than what we've done with the Smile. And since I've also migrated from Smile to this, the differences that I've noticed are one in the docking, like you said, sir, like you mentioned. There is a small learning curve for the docking, but once we get used to it, I think it takes about 3 or 4 cases to get used to it. And once that is done, it's quite easy. And again, the biconvex advantage, that's what they say is the healing is a little faster. The corneal nerve damage, because it's parallel to the anterior surface, it is a little faster. And the microfolds, I don't think we can see it clinically in our everyday practice, but that is what theoretically they say, that the microfolds are lesser, especially when we're correcting higher powers.
Have you tried, felt the need to do an energy optimization, Silk, like a few cases and you modified certain aspects of it?
Yes,
Or
ma'am. So
right from the
initially,
word go, it was going well.
So from initially we did start with a higher energy. So right now we are at 40 and 38, but we started with higher around 43 and 40. But initially we did see the first day post-op results to be a little lesser than what we are seeing today. So as the cases went on, we did reduce the energy till what we found was comfortable for dissection. From the dissection point of view, it was comfortable. And so consistently we've been saying day 1 6/6 vision in most of our patients. And they're quite happy.
Post-operatively, you manage these patients similarly, Smile and Silk?
Yes, ma'am. Yes, ma'am. The steroid regimen and everything is the same.
So that was again a very crisp session. Dr. Namrata, shall we move on to our third speaker?
Yeah, please.
Yeah. So thanks, Saundarya. So we go on to our next speaker, Dr. Shreyash Ramurthy, who's the Managing Director of the Eye Foundation Group of Hospitals and also a Senior Consultant in Cataract, Cornea and Refractive Services. And he would be showing us a little different femtocataract with a small pupil. On to you.
Is the video being shared? Yeah. Yeah, thank you. So at the outset, I'd like to thank AOS for giving us this opportunity, and Namrata madam, always a pleasure being a part of your Surginar. So today I'll be presenting a patient with a hard brown cataract with a moderate pupil, as you can see in this video, which is a 5 mm pupil. You can play the video, please. 5 mm pupil, and this patient was also on alpha blockers with a history of BPH. Although on slit lamp examination, the iris musculature looked fairly normal. Can you play the video?
Sir, I'll send you the remote control. You also play the video. You can click on the screen just. Yes.
Okay. Right. So this is just the catalyst dock being done. I've edited the catalyst dock in the interest of time, but this is essentially to show that, you know, the rexes that you're performing will usually be about 1 millimeter lower than your pupil size. So this was around 5 mm pupil. Tech support, if you could mute yourself, please.
Rama.
Mr. Tech support.
Tech
If you
support.
if you can mute yourself.
Please mute.
So essentially, if you can see, this is the diameter of the rexus that I was going to get. And considering that it was a hard brown nucleus, what I'm doing here is manually adjusting the size of the pupil to make it appear a little larger, so that how the laser detects is 0.5 millimeter from the area which I have set as the pupil. So instead of a 4.2, which I was originally getting, I'm now getting a 4.7 mm rexus. And this is closer to the pupillary margin, but as you can see right through the laser delivery, it is not touching the pupil at any point of time. And the rexus is usually very fast with the catalyst system. It's over in about 1 second, 1.1 second. And subsequently, I'm making 6 quadrants. You could do a segmentation as well as softening, but in this case, I just chose to do a segmentation. Oftentimes, what can happen after a laser is that because of the release of prostaglandins, the pupillary size can come down. And in many patients, once you inject a little bit of phenylephrine or xylocard, they usually dilate very well. But possibly because this was an older patient and also had a history of BPH, this pupil was not dilating very well. And this is when I decided that because being a fairly dense nucleus as well, I wanted to go ahead with a iris hooks in this particular case. So I'm staining the capsule. This is essentially, while making the iris hooks, I want to ensure that I don't disturb the rexus, because this is a rexus which has already been made by the laser. And because it was fairly close to the pupil, you also have to be careful that the rexus is completely intact and that it is doesn't have any tags which could result in a runoff in these situations. In the placement of iris hooks itself, though it's fairly routine, things to be kept in mind: make your incisions as peripheral as possible. You should see a little bit of bleeding. It should be as posterior limbal as possible. This ensures that when the hook is being placed, it is the iris is not drawn anteriorly and stays flat. The configuration of the iris is not drawn upwards. While putting the first hook, you have to be a little careful. Slide it in a little tangentially so that you hook only the iris margin and you don't disturb the rexus margin. Although the rexus has not been removed, and this is on purpose, I have left the rexus as it is because I want to check if it is completely intact. But I just slide it tangentially, as you saw here. And because it is stained and the edge of the rexus is visible, I know that I have only lifted the iris and I'm not tinting the anterior capsule. Once the first hook is placed, generally the iris is now, it's easier to slide in the remaining hooks, and you can just place the 4 hooks. Of course, you can use a 5th one if you feel it is necessary in these situations. Again, as you see, I went from the tinted part to the part which is not tinted, lifting the iris, ensuring, and because it is stained well, you can see that the rexus margin is still very much intact, and I have not disturbed the rexus margin while hooking the iris. Now, once the 4 hooks are in place, the next thing comes about where I plan my incision. So very often, if you place the incision band temporal, you could have a slight band of iris which is coming forward and keeps coming into your incision when you're putting the phaco probe inside. So what I do is I make the incision a little more oblique, that is closer to one of the hooks. And this ensures that, and also make a little more anterior incision and a slightly longer incision. So these are 3 points to be kept in mind. And here I'm using a 2.4 millimeter incision. And As you can see that the incision is going to start a little more anterior. Normally, I would make a slightly more posterior incision. So here I'm making it fairly clear corneal, and then it is a reasonably long incision, 1.2 millimeter. And then I just use this 26 gauge cystitome to just gather the rexus towards the center. This is essentially to ensure that there are no tags. Fortunately, in this case, and as was evidenced during the laser as well, it seemed fairly clear that the laser had been delivered within the pupillary margin, and it only went down while the patient was being shifted from the laser room to the operating theater. The hydro has to be fairly gentle. As you can see, some air bubbles will come forward, and especially in these dense nucleus, already the bag is quite full with this brown nucleus. So you have to make a gentle multi-quadrant hydro so that you don't cause any blowout, and these bubbles also have to be burped forward. Subsequently, ensuring that the nucleus is fairly mobile, rotating freely is very important. And I rotate it a few more times. This is essentially to dislodge the nucleus from the and the epinuclear material from the capsular fornices. And this rotation really helps subsequently during your chopping maneuvers and emulsification of the nucleus, easy removal of the nucleus. So I use a fairly long chopper. This is a 1.75 millimeter tip. And after clearing the central area, my go-to technique is a horizontal direct chop in these hard cataracts. As you can see, the nucleus dense core is fairly brown. And once I occlude and ensure that I just slide it beyond the rexus margin, dip down, and then separate the nucleus. It's important in these nuclei that you make sure that the central crater is separated, because if the posterior plate is not separated, then removal of the subsequent pieces can be quite challenging. So I also ensure that there's not too much lateral separation, because unequal forces at lateral separation can cause weakness of the zonular bag, and any asymmetric force can cause a weakness in the opposite direction. So each of these chops, and it's important in an LRCS case to also remember that each of these chops are made along the groove that is already created. Because if you go a little paracentral, the nucleus just tends to tilt and move away, and it doesn't go into the groove perfectly. So it's important that you chop along the pre-created grooves. And because these grooves are fairly deep and go within 400 microns of the posterior capsule, it is fairly easy to separate. It's also useful in some of these cases to do a little bit of multi-level chopping, as you can see here, go a little deeper and separate those dense posterior fibers. Those posterior fibers, if they are left intact, again, during removal of the pieces could be a little more challenging. I would like to make about 6 to 8 pieces at the outset, because I've made a 6-piece pattern, a hexagon pattern here. I'm removing the 6, first chopping it into 6 pieces first. And then if the pieces are a little large, I will sub-chop it as the quadrant removal is going on. Now I'm just starting the quadrant removal. And as you can see, this brown nucleus being emulsified by the Veritas machine. I will take a couple of minutes to talk about my settings here. So I'm using a fairly high vacuum of 550 and an AFR of 40. And the good thing about this machine is, despite the fact that I'm using fairly fast settings, I'm having a bottle height of only 45. And this is made possible by the presence of this advanced infusion systems. So Dr. Tamil Madam already spoke about the tubings being fairly narrow. So there are 2 factors which contribute. So the tubing being narrow helps in a greater rigidity. It has a soft inner core and dense inner core and a soft outer ring. This ensures that while the tubings are narrow, which gives better fluidic control, it also is compliant and there is no surge. Second is the active infusion. Now, what this infusion does is there is a gas infusion which goes into the bottle, and this is constantly done by active sensing mechanism. What it does is ensures that your bottle is always left inflated. And this inflated bottle maintains the anterior chamber stability even in these higher vacuums and higher AFRs that I'm using in this particular case. And there is absolutely no surge during the entire procedure, because there is a constant air pump which is pushing in air into the bottle as you're evacuating the pieces. So I just add a little bit of viscoelastic. You can see that because of the manipulation with the chopper, there's a little bit of iris which is tending to come towards the side port, and this is a fairly long chopper. So, the stretch of the side port would have also been there, which is causing some iris to come towards it. And then now, as you can see, I keep sub-chopping some of the smaller pieces and into smaller pieces and keep emulsifying it. Always keeping the phaco probe at the center, ensuring that you don't come towards the incision when you're evacuating the pieces. The stability with these machines are so good that really even during the last piece, you don't really have to change your settings. I don't use any epinuclear mode, or for the last piece, I don't change any settings. I just go ahead with the same quadrant removal, and the pieces do come out fairly efficiently. Again, just ensuring that you separate. There's small bits of attachment between the pieces. And when you have a very large piece to handle towards the end, there is a tendency for the phaco to become a little more anterior. And therefore, sub-chopping these pieces to keep it as small as possible is very important. And then you can see that the followability is also quite good. And the pieces are going in with a fair bit of ease, even in this dense nucleus. It's also important that in these laser cataracts with these dilated pupils with the iris hooks, that some of the pieces could be hiding beneath the iris, and it's important that you just wiggle it around to ensure that some of these pieces get dislodged, and that's the end of the phaco emulsification. I then go on to my bimanual IA, and there's a little bit of epinuclear sheet which is left, which is not separated from the cortex. And that is now being removed first. With the laser cataract, again, because of the vertical cut, you may not get these anterior tags, which you normally get after your phaco for removing the cortex. So going a little bit deeper into the fornices of the bag towards the equator, and then removing the cortex in a tangential manner is important. After removing the cortex, I'm about to do a little bit of polishing. Again, this is being done with the Venturi mode, similar to what Dr. Tamil was also showing. And that's fairly efficient. It helps in removing the cortex quite quickly. And then after a little bit of polishing, I removed the cortex from the other side. You can see that the iris is tending to come out, so it can tent up because of the iris hooks as well. So using the other instrument to slightly press it down, dip it down, and rather than pushing at the iris is important. And then you can go ahead and go ahead with the IOL implantation. So because this is a screw type injector, I'm using viscoelastic. Otherwise, I prefer a irrigation assisted injection. And I'm putting in an iHands IOL. The iHands IOL has become our go-to monocular lens, and it does give a little bit of good quality intermediate vision for these patients, a lesser ad for near as well. Very often these patients are able to get away with a 1.5 ad to get a N6 vision. Once the IOL is in place, I go ahead to remove the iris hooks. And the ideal technique for removing the iris hooks as well is also to be noted that you don't injure the iris sphincters, that you actually push the iris hook forward. After grasping it, you push it forward, release it. Once it's released from the pupillary edge, then you can lift it up and remove it. And this is the more atraumatic fashion of removing the iris hooks. It's important that we don't pull at it directly, because this can cause more sphincter tears, and you can have a much more irregular pupil than what you would normally have once you've used iris hooks. Again, there is a little bit of iris at the side port. Again, because of the manipulation, a little bit of potential IFIs in this patient, and as well as the fact that my chopper was a little longer, which is, which could have distorted the side port. So again, it's important while closing the case and doing my IA, I ensure that I don't disturb the iris further. So I just slightly draw it in, and then I start my irrigation. So if I start my irrigation forward, more of the iris will prolapse, and this will cause a cyclical effect with the further more and more iris prolapsing and causing greater iatrogenic damage to the iris. Again, just removing the viscoelastic is the fairly simple. You can just rock the lens side to side to bring out the viscoelastic from all directions. You could also lift up the lens and remove the viscoelastic from the posterior segment, posterior chamber. Again, I'm trying to bring the iris forward, but even then there is a little bit of prolapse. So now again, this is an important step that you don't overhydrate, just a gentle hydration. Again, you can see that the iris is out. The eye is still very soft. To keep the eye soft, I just slightly hydrated that side port. And then with the repositor, I nicely draw out the iris towards the center and then go ahead with the hydration. If you overhydrate, again, more of the iris will come out and then closing the case will become a little difficult. And once it's pushed inside and then you inject fluid over the iris, it generally tends to remain inside. And then I just inject a little bit of intracameral moxifloxacin towards the end. And that's the end of the case. Thank you.
A wonderful talk, Shreyesh, very explicit. I would just have to leave this meeting for a short while. So sorry, Dr. Namrata and Ramurthy, I'll get back soonest. Thank you.
So, Shreyas, again, very nicely demonstrated. I just wanted to know a couple of things. One was that you very nicely demonstrated that you had made chops on the flax platform. But is there any method of softening the nucleus as well, because it was a hard cataract?
Yes, madam.
Or would you just go with this? Would you want to do both, or would you just go with chops?
Generally, I do both, madam. I do softening and segmentation as well, as I mentioned at the beginning. But in this particular case, because the pupil was quite small, the space that you will give between the segment and softening, and I wanted at least to have 6 pieces. If you're doing 4, you'll still have more spaces, but I wanted at least 6 in this. And once you do 6 pieces with a small pupil, you'll hardly get any cubes. So, and I didn't want to increase the laser time, so I just kept it as a simple sextant and didn't do any softening in this particular case.
I think very nicely you explained how with the small pupil also you could get a rhexis which was a little larger than your pupillary size. Can you just explain that? Because
Yes,
that is something which is very useful. And can you do it on other platforms also?
Yes, madam. So essentially in this, there is an auto detection of the pupil, and usually the rhexis comes 0.5 millimeter from the pupillary margin. So essentially it's 1 millimeter smaller than the pupil size. So if you have a 5 mm round pupil, you'll probably end up with a 4 mm rhexis. But here I have manually adjusted the, what was automatically detected as the pupil, and this has been manually set. And from that manual margin, it takes 0.5 millimeter. So in essence, I'm closer to the pupillary margin. So I can get away with a slightly larger rhexis. So instead of a 4.1 as I would have entered, I got a 4.7, which makes it a little more convenient in this particular cases. And yes, madam, it can be done in the LensX platform with Z8. I'm not very sure. I don't think I've done this with a Z8 machine. But it is possible to adjust the position of the laser with the Z8 as well.
Dr. Ramamurthy, you would want to ask something?
Oh, I think a very nice demonstration, Shreyesh. I mean, just as a follow-up to what was already mentioned, you nicely demonstrated the enlargement of the rhexis, but the fact that it went closer to the pupillary margin, could it have been contributing to the slight meiosis that you had? Normally, we put while the patient is waiting to be shifted, we put a drop of NSAID and dilating drops also, especially if we're doing a series of cases. And how often do you encounter this problem?
I think it would have contributed. I mean, I definitely cannot say it wouldn't have contributed towards the pupillary meiosis, because although the laser didn't directly hit the pupillary edge, it was very close to the pupil. So possibly this prostaglandin release, which you're talking about, is also very close to the pupil, which can increase the amount of meiosis. We encounter this situation fairly commonly, especially like you mentioned, when we're doing a series of cases. But most of the time, when you inject a little bit of phenylephrine, it dilates, and it's very rarely a problem. But in this particular patient, possibly because of age or a component of IFIs, the pupil didn't dilate once it came down.
And two other questions. One is the this is a fairly hard cataract, and the magnetic followability of the nuclear pieces were very impressive in the sense that you kept your phaco probe right in the center and hardly had to maneuver much with your second instrument also, and they just flowed in. And do you think you have been using a signature probe for a long time? With this Veritas, has it made a significantly difference over that? You did explain certain features. The second question I have is that do you do any amount of micro monovision with the eye hands just to steal a little bit of near vision?
So to answer the first question, with the Veritas, I found that the chamber stability tends to be a little better, even when you're using reasonably high vacuum and high flow rate settings compared to the Signature Pro. And most importantly, with this new cassette which is available, that is the AI packs which is available with the Veritas, there is an active infusion which enables us to keep the bottle lower. So in essence, I've kept it at only around 45 height, millimeters of mercury pressure, but it gives you an additional 30 because of the active infusion of the gas which happens during your phaco. So with a lower bottle height, you get to have a higher amount of stability. So if with 45 centimeters itself, you get a 80 centimeter bottle height effect. Subsequently, with the IHANS lens, while we don't do it as a routine, but for patients who are a little conscious, we have tried monovision or micro monovision, and it does work to some extent, though I have not been successful in making patients avoid readers altogether. They do still require reading glasses, but they're very comfortable with intermediate, with computer, cell phone usage, etc., and practical day-to-day scenarios.
I personally don't use micro monovision at all with eye hands. That's a point I wanted to bring about, though it's been recommended, because this is a lens where we want crisp distance vision and good intermediate vision, which you end up achieving if you hit metropia either with eye hands or eye hands toric. And then as for our counseling is always towards using readers. So I know that several surgeons in our own group do a bit of a mixing and matching, but I personally feel that to get the best out of these lenses is what I would do.
So I completely agree with you, Dr. Ramamurthy. I think we should use it for what it is meant to be used and not try to alter, because I think the whole optics runs on that. So thank you, Shreyas. I think that was an excellent case again. I think the best part about the cases today are that they are not normal cases. Each one of them is different. Each one of them is actually quite difficult to do and teaches you tricks and tips on how to deal with them. So the next surgeon is Dr. Rakshit Nathan, who's again consultant at Cornea, at the Eye Foundation in Cornea, Cataract and Refractive Services, Coimbatore. And over to you, Rakshit, for your surgery.
Thank you so much, ma'am. Thanks, Namrata ma'am and AOS for this opportunity. If my video could be shared. So essentially just shifting gears, in fact, opposite to what madam has just mentioned. Now I'm going to show a very normal case in contrast to a lot of the very technically challenging stuff that has been shown. I think we can start the video. So this is a very well dilated pupil in a 48-year-old gentleman. And yes, I can start playing. So this is just a posterior subcapsular cataract. Now this is a patient I had seen pre-op, was very confused as to what IOL should be chosen, and we went ahead and chose Piosi for him after discussing in detail his visual needs. So I go ahead and make my paracenteses and then go ahead and instill some phenocaine into the eye, to not really for dilation now, but just to ensure that the pupil stays dilated during the case. Sometimes if you don't do that, you could have meiosis while the case is still in progress. So this helps avoid that. So I use it in all cases routinely. I also am a proponent of using trypan blue staining for all cases, because the cost benefit is really favorable. At least in our scenario, we're not paying hundreds of dollars like in the US. So it's available, and we know that it's pretty safe. So I go ahead and stain the anterior lens capsule in all my cases, irrespective of the red glow, and just washing out the trypan blue completely. And then having a fill of OVD, once again, traversing beyond the bubble so that the entirety of this so-called exchange, OVD fluid air exchange can be done out of the AC, and then I can proceed with the capsular rhexis here. So this is this was my first case of POC, so I'm also a little nervous, and the patient is also a little nervous. This is his first eye. I also did the other eye when he did a POC in that eye as well. So going ahead and commencing with the capsular rhexis here, I'm looking at 5 mm or so rhexis to ensure a complete 360-degree overlap, which is of course quite important, as we know, in all IOLs, particularly with premium IOLs where we want centration to be bang on. So proceeding with this, yes, of course, trypan blow also helps in the fact that, you know, it kind of reduces the amount of pliability of the ALC, makes it a little bit more easy to handle, especially when you have a slightly younger patient, although this patient was close to 50, so I don't know to what extent would have helped, but we achieve a rather reasonable rhexis, and we can go ahead to make the main incision now. So I always use a number 15 blade to make my initial groove. Because with the reuse of keratomes, some are not sharp, some are sharp. So this lets me have at least one part of the incision which is completely standard. And I always nick those posterior limbal vessels because the wound heals a lot better. Here I'm making a 2.4 mm incision with a dual bevel keratome. And once this is made, I can then move on to hydro dissection. So I go burp out some of the visco and the ALC that has come off, and I'm just trying to achieve a fluid wave here. I'm looking to delineate because this is a soft cataract. My whole modus operandi is going to be to try and isolate that central nugget. And thankfully, I see this nice golden ring, which is of course characteristic for hydrodelineation. And this has a very small bit of nuclear sclerosis. This is an NS1 nuclear sclerosis. So I do feel that I'll get a little bit of hold. So before I commence with phacoemulsification, going ahead, rotating this, I have reasonably good mobility. Do a few more spins to kind of loosen up the cortex. That should hopefully make cortex aspiration a little easier. So entering with my phaco probe here, and with a long blunt chopper, getting some of that superficial cortex and epinuclear matter out of the way before I start. Then going ahead, and I'm just using very minimal power, mostly vacuum here. And so with that chop, it's so soft that the piece actually gets into the phaco probe. So the nugget is made pretty quick work of over here, just rotating it, getting it all into the phaco tip quite effortlessly here, at least with respect to the central endonucleus. Mostly just vacuum with a few short bursts of power. And here I need to try and deal with this epinuclear shell here, trying to kind of disengage it from its attachment to the capsular bag and the cortex that is adherent to the capsular bag. Just going cloaca by cloaca, trying to carousel this around so that it all can come into the anterior chamber. So slowly but surely, being very tentative, wouldn't want to end up with a problem here. So just trying to aspirate as much as possible in the center rather than at the periphery, which is where things are expected to go wrong. So not able to get a good hold to try and flip this entire thing into the AC. But I'm trying at all edges to try and find one edge where this is possible. So inadvertently, some of it is aspirated. And now I'm basically on irrigation aspiration mode. I'm not using any power. And this is stubborn because it's stuck. Diametrical ends of this epinuclear shell are within the ALC rim, so it's not going to come out. So I should have pulled it through one end. Nevertheless, after some of it has already gone into the probe, I'm able to get one edge out, and now I can just aspirate the remaining bit. This could have all been avoided if I'd done a proper cleaving hydrodissection, which again, we know reduces the amount of time that needs to be spent on this maneuver. So filling up the bag again with OVD, we have a thin layer, a flimsy layer of epinucleus that remains along with the cortex. And yes, we can also see that the posterior subcapsular element is very much visible in retroillumination. And so we go ahead, I switch to bimanual irrigation aspiration because I feel it's safer and I can be more in control of my movements here. So essentially what I'm going to do is what Tamil Madam also very elegantly described, the cortical pulley method, where if you pull the cortex, the epinucleus shell along with it comes. This works very well, especially if you have a very flimsy layer of epinucleus that remains. If you have a slightly thicker epinucleus shell, you might be exerting a little bit more traction than you want on the zonular apparatus. which is not ideal. But in this case, it really comes out quite freely. So I'm able to use this cortical pulley system to kind of just get all these cloacas of epinucleus and cortex. So once I'm done with the inferior half, I go ahead and switch hands, which is what the bimanual irrigation aspirate system is good at doing, giving 360-degree coverage, as was mentioned. And once again, just aspirating cloaca by cloaca, ensuring I get all of it, not leaving anything behind. So at this point in time, all of it is done. I do have a little bit of remnant that the PSC that is kept on the posterior capsule. I'm going ahead and polishing this, just getting that clear before I then go ahead with the implantation of the IOL. So once the posterior capsule polishing is done, I can come out of the eye and of course, this is a screw type injector. I'm going to use the Simplicity injector and I'm going to implant a POC lens over here. So I will need to fill the bag with HPMC. So the AC and the capsular bag are both filled with HPMC, and then go ahead. And this is a preloaded system as was described. This is very simple to use. This is a 20.5 diopter POC IOL that comes in the Simplicity injector system. So the delivery is fairly easy, similar to the other injector that was shown by the Unfolder Platinum series, and they both work the same way. This is of course a disposable single-use preloaded cartridge, and the IOL quite easily goes through this 2.4 millimeter incision. So delivering the leading haptic that goes in the right way. The 7 is the orientation of the leading haptic, which is the correct orientation, of course, and we can then push down the IOL trailing haptic behind the anterior capsular rim, and now the IOL is in place. So now I can go ahead with washing out viscoelastic from the eye. So what I like to do is I like to have the irrigation cannula in my right hand because that's my dominant hand, and I find it much easier to really get underneath the IOL and aspirate that cortex from behind the IOL. So sometimes you could be a little tentative if if more often than not we have this in our non-dominant hand, the irrigation hand. So now I just do a passive wash, stay there for a bit. I take a lot of time in trying to get the HPMC out, ensuring that I see all those spaghetti strands disappearing from both in front and behind the IOL and also from the anterior chamber. So I take probably more time than is warranted for a visco wash, but despite this not being a toric, I'm a bit obsessed with clearing out the entire eye of viscoelastic before I close the case. So then again, ensuring that all of it is done. So the IOL looks well centered. The rexis is of appropriate size, and as mentioned before, the POC lens itself, the anterior surface is identical to the Technis lens, the Technis monofocal lens. It's the posterior surface which is supposed to be the refractive surface of the POC IOL. So there's supposed to be a continuous gradation in the change of the posterior surface, which contributes to its enhanced depth of focus capabilities. So this is where the POC. So you don't really see, even in the eye hands, if one notices very closely, there is a small central hump or a bullet that one can notice. But in the POC, there's nothing really discernible in the central part, at least of the anterior part of the IOL. So the entirety of its EDOF capability is on the posterior surface. So before I come out of the eye, I'm just kind of hydrating the port so that I don't allow my AC to collapse, so the IOL can remain stable within the bag, and also so that some of this bleeding from the main incision doesn't leak into the anterior chamber, which I would otherwise need to wash out separately. So I keep the AC formed, don't allow it to collapse. Patient does make a few movements, but I'm able to then hydrate both these incisions minimally, and going ahead and just sweeping for any visco in the anterior chamber, and I think we can now successfully and safely close the case. The bleeding oozing from the incision really indicates that there is no leak, so the case can now be closed. So thank you very much for your patient listening.
Thank you so much, Rakshit. Again, I think it is sometimes as challenging to do a soft cataract as is a hard cataract. And again, I think you really managed very well because the cheese wiring occurs and then your epinucleus, doesn't separate the way you want it to be.
True.
So I think again that was done well, and I think one thing that needs to be noticed is that whether it was a hard cataract or soft cataract, which we saw today, small pupil or mid dilated pupil, and yet Veritas, helped in all situations, and it was possible to maintain the chamber rock solid. Whether it was shallow AC, which was with Dr. Tamal Rasi, the machine, stood by the surgeon. So I think that is very important. Dr. Ramamurthy, would you want to comment?
Yeah, I completely agree with you, Namrata. I mean, our experience has also been very good. And as Shreyesh also emphasized, we're able to lower down our bottle height and IOP settings with this, and with the even in spite of slightly aggressive fluidics parameters, we get a very good chamber stability, which stands us in good stead in all situations. And one thing I would have done slightly differently, Rakshit, is that your surgery was wonderful. You did a great job. Is that I would not have done hydrodelineation. I would have just done a hydrodissection and then rotated the nucleus significantly 2, 3 times round in these soft cataracts. In that case, what I find is with a very nice rexis, 5.5 millimeter rexis that you had, almost the entire lens material flows out and as a bulk, and then there is little extra time spent upon epinucleus removal as well as the cortical aspiration is significantly reduced. Otherwise, everything else was very well done. Just coming to the point of lenses, I mean, I asked this question to Shreyesh. What about this lens? This obviously gives us a little more add power compared to an eye hands. Would you mix and match with these lenses? Or do you play around with the power of these lenses?
While I have not done it myself, it does look like it might give a good result because we're seeing patients with the PRC who have either a near add of about 0.751. And at least based on the defocus curve of the lens itself, it does tolerate a slight bit of myopia. So, especially for a lens which is at least spoken of as a presbyopia correcting lens, which we are not really promising at present when you implant it for emetropia on both eyes. Uh, Aiming for a small micromonovision, a 0.5 diopter, the 0.75 diopters, is likely to have the patient spectacle independent.
I think that's a very relevant point. I mean, we have in our center implanted more than 100 POC IOLs, and slowly, though in the initial study, we had to aim at only emetropia bilaterally. Over time, we have gathered experience. Now, what I routinely do, and this is my go-to lens because it offers a significant amount of range of vision. At the same time, the dysphotopsia profile is comparable to that of a monofocal lens. So in these cases, what I do is to always aim at the first minus in the first eye and the second minus in the second eye. And by that, I mean that if the power shown is 22.1, I implant 22.5 in the first eye and then go ahead and implant a 23 in the second eye. And what I find with this is that bilaterally implanted less than 20% of my cases actually go ahead and buy a pair of spectacles. Why I'm saying buy a pair of spectacles, it's not as if they all read N6, but they might be reading unilaterally N8 and they may read a 0.5 diopter of power for comfortable reading vision. But then bilaterally implanted, these patients with this first minus and second minus seem to get a good range of vision so that most of their activities they are able to manage quite comfortably. And the fact that you may leave behind these patients about minus 0.5 diopters of myopia, but because of the profile of the focus of the beam, the loss in distant visual acuity is not significant. They end up getting about 6.9 to 6.6 parts vision. So bilaterally implanted with the slight adjustment in power, many of these patients are bereft of glasses and with dysphotopsia profile similar to a monofocal lens. I think this is what I find exciting about this lens. Obviously, all the other advantages the Technis platform is there. But apart from that, the fact there's no diffractive rings, there's no refractive zones, there's no playing around with the spherical aberration. It has a minus 0.27 Q value on the anterior surface. The toric version is also available. So slowly, for monofocal lenses, we are replacing with the monofocal plus lens like our hands. And when a patient comes with multifocal request for multifocality, but concerned about dysphotopsia, at least in my hands, I find that using this lens with a slight adjustment of the refractive error or the defocus does help me get good results.
So I think that was very well explained, and which is also required because apart from the surgery, the decision making is the most important thing as far as emetropia or as far as bilateral vision is concerned. So I think with this we come to the last surgery, and that is going to be by Dr. Eman Khan, who's a consultant at Glaucoma and Cataract Services of the Eye Foundation, Coimbatore. So over to you, Dr. Eman, for your surgery.
Thank you, ma'am. And at the outset, I would like to thank Ramurthy sir, Chitra madam, and Namrata madam for this opportunity. Could you please play the video? Yeah, so this is a case which I have operated, which is a hypermature cataract, and I'll be planning to implant a eye-enhanced toric lens in this case. So these total or hypermature cataracts, I think the first and most important step you need to do is get a good staining of the anterior lens capsule. So not only for the excess creation, it also highlights any anterior capsular fibrosis which gets highlighted because of the trypan blue. So you want to look for some sort of like folds on the anterior capsule or kind of white specks that kind of get highlighted because of the trypan blue stain. I like to let it stain for 5 to 10 seconds before washing it out. And so in this particular case, there was a small areas of white specks on the right side over here, which caught my attention. And I was just wondering if though that might be the area if where the rexus might show some resistance. So that was something I had to keep in mind as I was planning the rexus. So once I create my clear corneal incision, I'm trying to achieve a 5 to 5.25 millimeter rexus to get a nice overlap for the toric IOL. So I try to start my rexus a little bit away from that area. And as I'm going around, I'm just looking for any sort of resistance if I feel anything while I'm doing the rexus. Luckily, in this case, that area didn't seem to show any resistance, and I was able to actually quite easily complete a 5 millimeter rexus in this case. And with most total cataracts, I avoid a hydrodissection, but in this case, I just thought since it's slightly on the hypermature side, I'll just sweep across, do a little bit of hydrodissection just to loosen up if any additions are present. And for this nucleus management, I think the most critical point we have to understand is the nucleus inside is usually free floating in nature. So the management of that is slightly challenging. Sometimes you end up getting quite a huge brown nucleus behind this whitish material. But as you'll see in this case, once I clear up the epinuclear bit on the top, the nucleus density was around 3 to 3 plus or so. So what I planned for this was to get a small central groove in the center, just so that I can get a good hold of the central core of the nucleus. So this central core hold is what actually helps you get a good horizontal chop. So I'm just going around the equator and just trying to separate it and get a horizontal chop across. So you can see the nucleus is kind of disappearing to the right because of how much space is there. It's kind of free floating, but one tip I would say here is to not be very aggressive in the cortical or the epinuclear removal, which you can see in the corners there. If you remove that tumor early, then you might get up losing the mild support you might get because of those epinuclear bits. So I'm just going around with the horizontal chops. I try to get around 6 pieces or so. So holding the central core really makes the chops very easy. So now coming to the emulsification. So with Madam already mentioned, Tamil Madam already mentioned about the Ellipse FX handpiece. So it uses the elliptical phaco emulsification, which combines the transverse, longitudinal, and torsional phaco. So it does make the cutting very efficient. And my parameters for this case were around power of 40%, aspiration flow rate of 34, and vacuum of 400. So quite modest settings, but as you can see, it's doing very easily kind of cutting through and emulsifying and aspirating the nucleus. One extra point I would like to add in these slightly more hypermature cases is you keep a very close watch on the posterior capsule. There tends to be some amount of zonular weakness that can cause fluid misdirection and pushing up of the posterior capsule. I always kind of keep the blunt instrument below my instrument for the last couple of pieces just to have that extra level of safety. Having said that, already discussed the different parameters. I mean, the Veritas Vision System having advanced tubing and intelligent occlusing stenting. So that causes it to be a very stable chamber. And so in this case, luckily the posterior capsule was not very mobile, and I was able to complete the case quite safely. So the final bit of epinucleus is aspirated out. And one extra point here I would like to add is any total cataracts or hypermature cataracts, I really spend a lot of time just hydrating kind of the equator, the fornixes of the bag, because the cortical matter which is present is very thin and very friable. So when you're trying to do a cortex aspiration in these cases, you have a higher chance of holding the bag and sometimes end up causing a zonular dialysis. There is also a small bit of uh, opacification on the posterior capsule over here. I did try to hydrate that area and just check if it kind of peels off a little bit, but it didn't seem to be moving at all. Sometimes you're able to peel off these plaques if you get a plane. So I thought I should leave it alone, considering it's not in the central visual axis. So with the cortex wash, again, as I mentioned, you don't want to be too aggressive with your vacuum. You can go a little bit lower with your foot pedal. You can just control it. And since you have hydrated and kind of loosened up that those small fibrils of cortex, they kind of get aspirated very easily, and it's a more safer way of aspirating these cortex without causing a zonular dialysis. So very minimal cortex was there in this case. And so I'll be implanting the eye-hand toric lens in this case. So as I'm implanting it, I think we already had some discussion about it, but just to summarize, it's more of a monofocal plus lens based on refractive technology, and features continuous higher order acerate surface. So it has no rings and no zones, as you will see as I'm implanting the lens. So it looks exactly like a monofocal variant, and it even shares the same base geometry, material, and A constant as the Technis single piece variant. So, but the only difference is it has a slight increase in curvature in the center, which allows for an improved intermediate vision. And as we already discussed, we don't really promise spectacle independence with these lenses, but they do definitely have an advantage over the standard monofocals. So as I'm just sort of keeping the lens into its desired axis, so sometimes this haptics get stuck to each other, so a little bit of coaxing and they open up. But once they open up and once they open up fully, they kind of stay in place and they don't really move a lot. So at the end, I just when I'm hydrating, I try to hydrate with the irrigation on main port and side port. And I'm a little bit, I take a lot of time with hydration just to ensure that there's complete water tightness. Just checking with the bud to ensure that the anterior chamber is completely watertight. And with these toric lenses, I think ever so slightly, if you keep it, on the softer side, it just encourages contact between the lens and the posterior capsule, and that likely, reduces the chance of early postoperative rotation of these IOLs. So that was the case. Thank you so much.
Thank you, Eamon. I think again another very tough situation. I've managed so well, effortlessly. So I think we've had any comments, Dr. Ramamurthy, or anybody would want to give?
I think very nicely demonstrated, and I especially liked your point, Ayman, about it's not often emphasized washing the capsular bag in these total cataracts, because invariably, even after implanting the lens, sometimes bits of cortical matter flow out. So just washing it out and removing it completely is very important. Beautiful rexes, well demonstrated. I think only we have been talking, and other
People have
surgeons,
not
I
been
mean, if you
talking,
have,
yeah. So any comments from anybody? All of them did such brilliant surgeries,
yes.
and it
I'm
is
proud of
nice
them.
to see the young brigade performing so well. Anybody would want to comment on anything?
Just to quickly add, madam, I mean, especially with Ayman's case, I mean, can be quite tricky and challenging in these situations with hypermature cataracts. And I would again like to highlight the point which he was mentioning, that doing a horizontal chop in these cases, drawing the nucleus slightly upwards so that all your forces are centripetal, because these bags also tend to be a little weak, and even burying into the nucleus can be a little challenging at times because the nucleus keeps moving around. So stabilizing it with a chopper and then burying deep enough so that you can then draw the nucleus, and when you can visualize one pole, and then completing the chop, I think is extremely important, and that was beautifully demonstrated by Ayman. And there's again a small point regarding the Veritas in this situation. Because air gas infusion is constantly happening, even till the last few drops which is left in the bottle, there is absolutely no chamber fluctuation. So which generally in these cases we are worried during the last piece when you have very little fluid left in the bottle, whether you need to change it and you need to keep a watch. But that's really not the case. Till the very last drop, the chamber maintenance is excellent, and even the bottle remains inflated because of the constant air infusion, and the pressure is constantly maintained.
So I think we finished bang on time. I mean, initially I was just thinking that 5 cases normally will not be over in this time, but bang on time with and I think it was curated very well. The whole thing was curated very well with not a moment or a minute which did not go without information. And so hats off and thanks to all of you for doing this. Otherwise, and this is a very valuable resource which is going to stay on the net for everybody to watch later. Of course, we did have a great audience. And anything, Dr. Ramamurthy, or concluding remark, and then Chitra, and then I think we can close this.
Thank you, Namrata. Always a pleasure to be interacting with you and being on the same panel as you. And truly appreciate J&J not only for bringing us excellent machines and lenses, but also giving us a platform to propagate our ideas. I think, I truly enjoyed this 1.5 hours and array of cases and all very well done. Congratulations to all the surgeons.
Thank you very much, Dr. Namrata, for giving us this wonderful opportunity. And I truly felt so proud of being part of Eye Foundation and this very smart group of people who are so sure about what they know. And it is wonderful that you create platforms for all these young heroes and heroines to project themselves all over the country. So that is something I think each of us, that's one message for us that we need to be so thankful about. And thank you so much, J&J, for coming out with such great technical support and great gadgets. And all of us have learned a lot more in the course of this webinar. Thank you.
Thank you. I would particularly like to thank Johnson & Johnson, Mr. Sami, who's been trying to coordinate this with all of us for last 2 to 3 weeks, and I'm glad this happened. I would like to thank the audiovisual team behind. I do take the name of one gentleman always in Surginar because I think to him we owe the credit of the word Surginar, and that is Mr. Jaswinder from Johnson & Johnson, who's not there with us, but he was the one with whom both, we discussed that we'll do a Surginar and we'll do a live surgery, which will be online. So we do remember him today, and thank you, Johnson & Johnson, again for a very great show and for a yet, I think, if I may say so, this is the best Surginar that way we've had in terms of the takeaway points and the messages and the surgeries and the fact that it was done by all the young surgeons. So thank you, Eye Foundation, for letting us peep into your operation theater.
Coming from you, Namrata, it means a lot.
Yeah, really means a lot. We will treasure these words with us.
Yeah, thank you.
Thank you.
Thank you.
Thank you. Thank you.
Thank you.